Dear Chair, dear audience, my PhD title is Developmental Defects of Enamel, Etiological Aspects and Clinical Management. My name is Mlinkó. I'm working at the Department of Pediatric Dentistry and Orthodontics, and my vision is to improve the life quality of children with developmental defects of enamel with the better clinical assessment, and my mission is to discover causes of these defects and find new intervention protocols that are improving pediatric dentistry. To achieve this mission, these three specific goals are my the two meta-analyses and randomized clinical trial protocol, which I will explain ahead. The first is investigating different types of antibiotics at early childhood as risk factors in molar incisor hypomineralization. The abbreviation is MIH, and I will use it from now. This is a systematic review and meta-analysis. The background is that this MIH is affecting the first permanent molars and incisors mainly, and it is the most frequent enamel disturbance with the global prevalence of 13.5%. The etiology is still unclear. What we know is that the amelogenesis of the affected teeth are at the same chronological time. We already know that the tetracycline is harmful in the dental development, but we have less knowledge regarding to the other types from this therapeutic class. So our aim is to evaluate the strengths between early childhood antibiotic intake and MIH. Our question is that do early childhood antibiotic intake increase the risk of MIH? The population would be children. The exposure is the different antibiotic types, and the outcome is the molar incisor hypomineralization. Our hypothesis is that early childhood antibiotic intake increased the risk of MIH, and our clinical implication is to recognize opportunities for prevention. Here is our systematic search with 3 different databases and 2 different domains, and our flowchart of selection, which ended 36 eligible articles. The outcome is the molar incisor hypomineralization in all of our finished analyses, which included the risk assessment of antibiotic intakes. The outcome measurement is odds ratio with 95% confidence intervals. The first analysis is a general antibiotic intake at early childhood, which affect the MIH development. Early childhood means the first 4 years of life when these affected teeth are under development. In our study, we ended at 20,077 patients in the population. We could compare the control groups, so the healthy patients with the MIH-affected patients who had taken or hadn't taken antibiotics in these first 4 years of life. The study designs were used by the subgroup analysis, so we had case control and cross-sectional studies. We ended with 26 articles altogether. The heterogeneity level was 50%, which can be due to the fact that we know only the present or absent of antibiotic intake, and there is less information about the dose, the exposure time, and for what disease they have used different antibiotic types. So mathematically our result becomes significant, which means that the odds ratio is 1.56 was at the end. We investigated the different type of antibiotics as well, and also the prenatally taken antibiotics. We had fewer studies where we can see that the tendency is the same as in the general antibiotic intake, though they doesn't reach the significance level because of the low number of the studies. The strength is that in the general antibiotic intake, we reach the mathematical significant level with high population number, and we have a clear implication for further research in this field. The limitations are that these retrospective study designs, we cannot establish a strong cause-effect relationship for etiological factors. There are a low number of studies regarding to the different types, and the prognostic factor measurement is weaker. And also, in the methods, they used mainly questionnaires, and only a few studies used more valid medical records. So our conclusion is that early childhood antibiotic intake is associated with MIH. In the implication for practice, we suggest to avoid inappropriate antibiotic use, and there is a need for accurate medical documentation. In the research implication, the preclinical studies already suggesting the harmful effect of antibiotics in the mineral content of the teeth, although we don't have firm evidence for that. So the preclinical studies should aim to understand the causative mechanism of action regarding to the antibiotic effects in the development of MIH. And the first project progress, I finished the manuscript and is now by my SMS and supervisor for correction. Our target journal is the Pediatrics D1 journal. The second project is also a systematic review and meta-analysis investigating the association between phosphocalcic metabolism disorders and developmental defects of enamel. In the background, these defects can be qualitative or quantitative disturbances. In the primary and permanent dentition, almost the same prevalence. The background is that in the amelogenesis mineralization phase, the calcium and phosphates are needed for hydroxyapatite crystal growth, and if there is any change in the systematic calcium level, it can directly impact the formation of the enamel. These disorders can be from the pathology of organs which are responsible for calcium storage or hormonal regulation. And these changes can maybe influence the dental development. So our aim is to evaluate the impact of phosphocalcic metabolism disorders on the appearance of developmental defects of enamel. In our question framework, the population would be children with the different disorders in the exposure group, and the outcome would be the different developmental defects. In our hypothesis, the phosphocalcic metabolism disorders are increasing the risk of developmental defects of enamel. And in our clinical implication, that is the DDA can be a warning sign of general pathologies, and modifying some behaviors could limit the risk of developing DDA. In our preliminary search, we will use 3 databases with 3 different domains, and now I'm working on the Prospero registration. Our third project plan is the protocol of randomized control trial with comparing remineralization treatments in molar incisor hypomineralization. This defect is a qualitative enamel disturbance with high treatment needs. The enamel is porous, fragile, which can lead to post-eruptive enamel breakdown, caries, and even to tooth loss. The hypersensitivity is severe, which can impact the daily oral routine for children and also the clinical management. The early preventive approach would be important, but no definitive clinical protocols exist now. So our aim is to compare the 3 remineralization treatments for interventions in MIH. The clinical question is that does sodium fluoride varnish decrease the rate of hypomineralization and sensitivity compared to other materials like CPP, ACP, which is casein phosphopeptide and amorph calcium phosphate, or hydroxyapatite. The population would be children with MIH, and the mentioned agents would be the intervention control group, and the outcome would be both sensitivity and mineral density remineralization examination as well. The hypothesis is that the sodium fluoride varnish is superior to CPP, ACP, or hydroxyapatite. Our clinical implication is simple: the prevention and reduce hypersensitivity. In the protocol drafting, our eligibility criteria is based on the European Association of Pediatric Dentistry criteria system. In the intervention, we would like to use a 3-arm, the sodium fluoride varnish, the CPP, ACP, and the hydroxyapatite to compare. And in the outcome, for sensitivity measurement, we would use the Schiff-Coder sensitivity scale, the Wong-Baker Faces pain rating scale, and in the mineral density, we would use the quantitatively measuring laser fluorescence, the Diagnodent pen. So these are my 3 ongoing projects, and I would like to thank you for your attention with this quote: the aim of science is not to open the door to infinite wisdom, but to set some limit to infinite error. Thank you for your attention.
Until you're thinking, I may have one question. At the first study, just a technical question, that you presented the general response for any antibiotics. But those studies were completely different than the studies which using different specific antibiotics. So this was a subgroup analysis of the previous studies, or that was completely different studies?
No, there were studies which checked generally the antibiotic intake, and also they had information about the different types. And there were studies which used only or asked only just the general antibiotic intake. So there was a mixture of them.
Okay. And as far as I saw in the table, there was the range of the children was between 0 and 3 or 3. And how can you make the control group so they can question the mothers that the baby took any antibiotics previously? So that's
the limitation for the whole thing, that the development is earlier than when we can diagnose it, because we can diagnose this disease only at 8 or 4 years of age, or 8 or 9 years of age, or sometimes at around 6 when the first permanent molar is erupting, but we need to ask retrospectively. So that's why a medical record where we can easily access that which drugs the children have used, which disease they had, it would be more accurate than only ask the parents.
Thank you.
My question joined from the previous question. Have you any information the length of the antibiotic intake? It's a short time, or because the baby or the children had a chronic disease, he or she takes the longer time of the antibiotics, or did you investigate it or not?
We tried, but we had no question. There are only a few studies which now started to see the so adjusting the earlier illness and the antibiotic what they used for it, but mainly it was a present or absent of antibiotics, the present or absent of different diseases or other type of drugs. So we had only these listed informations what they had in the anamnesis. And for further, there are suggestions in the literature also for prospective studies and more valid recording for these to compare, because now it's risky to say that only the antibiotics are harmful because it's a multifactorial disease. So we don't know if the exposure time, for how many time they had. Some articles check that it was one time. So they have taken it only once, or it was a recurrent antibiotic intake, but we couldn't have enough information to compare them.